45 minutes or so, I should try and take you through a journey through sort of pain, trying to cover the trigeminal system, obviously for headaches, pain and sort of sensitisation, it's really important in headaches and migraines and stuff, and then how it affects the neck a little bit, and then trying to segue into a little bit of a practical, which we'll try later on. So quite a lot to cover. I think if I just talk really quickly, we should get through it all. Oh, okay. Is this in the screen?
You're fine, yeah.
Fine.
You're fine.
Yeah? Okay. I'm going to wander around because otherwise I'll be in that way as well, so I'll move. Or I can stand over here. Is this on screen? I got my head in.
No, you need to be the other side. You need to be the other side.
Just lounge here. Okay, so my name's Danny. I'm part of OPHM and I also teach the pain module in the British School of Osteopathy, now the UCO, University College of Osteopathy. And I'm also co-founder of a new research and mentoring clinic in East London called CORE. So, let's start with pain and sensitisation. I know different colleges have different amount of their course is spent on this, and there's some sort of new modules, some new ideas. It's also the sort of thing that neurology can just make people glaze over, so I'm going to try and make it relevant. How much are people happy with, so nociceptors, we should all know what nociceptors are, okay? So they're high threshold neurons that detect noxious stimulus, so obviously pinprick, high pressure, etc., high heat. Which one's is it the red one?
Yes.
So this is a nociceptor, and this will be the second order neuron in the dorsal horn of the spinal cord. Or over there. And then this is an A-beta sort of mechanoreceptor, or a low threshold afferent, which will be used for light touch, or mechanoreceptors in joints, etc. Okay, stretch receptors, that sort of thing. So we've got the nociceptors and the non-nociceptors. And the idea being that if you have a high threshold stimulus, so maybe flame, for example, it will fire off a nociceptor. And if you have a light touch at the bottom, so we have a feather here, then you're going to set off the light touch receptors. And they have a link, they have interneurons that link them, but they're kind of being masked, they're being permanently inhibited, or temporarily permanently inhibited. Okay, so those two stimuli shouldn't set off the other ones. When we talk about central sensitization, the idea is that, first of all, continuous stimulation of the nociceptors, which is one mechanism, leads to an increased sensitization of the second neuron. So the threshold goes down, so it takes much less to fire off that second neuron. So before you need a noxious stimulus, now much less of a stimulus can set off the same response. Okay, I've got a sort of diagram which should show this a bit better afterwards. Sorry. And what we get, if you stimulate, so if you have your pinprick and you touch it and they go, well, it's really sore. Okay, the idea is it's a noxious stimulus causing an increased pain response. So that we would call hyperalgesia, so an increased analgesic response. Whereas if you've got a feather on a mechanoreceptor, but now these interneurons are being opened up, they will now fire off the second order neuron, giving us a painful allodynia. Okay, so a feather on the skin or in migraine where you touch the scalp and it's painful. Okay, that is allodynia. If you take if you've got hairy arms like I do, and you take a hair and you pluck it, and you just don't pluck it, sorry, just pull it gently, refrain from plucking, and just pull it, it starts to get sore quite quickly. Okay, so that is slowly sensitizing. You're not damaging anything. You're just repeatedly annoying the delta fibers, leading to a bit of allodynia. Okay, so let's see this in a diagram. This is the arm because I didn't have time to make it into a head, but I wanted to keep it as an arm because it's much. I think we're happy with dorsal horns and the neurons to the rest of the body, but when it gets to the head, we get a little bit kind of confused. But the neurology is pretty much the same thing. Like the nervous system, the anatomy is not divided into segments except for the spinal nerve roots. We kind of make that up in the textbooks. Okay, it's all continuous. So when you get to the top of the C3, C2, C1, it then goes into the trigeminal system. It's a continuous transition. Okay, so this is just normal nociception. Okay, if you imagine a primary afferent going into the dorsal horn, and you've strained a tendon, you've got a bit of tennis elbow, you've gone and played 12 hours of tennis, and that's irritated, it's causing this sort of release of chemicals, which then goes up to the brain and says, ow, it hurts. That's our normal nociceptive pathway. What we also get at the same time, and if you take your nail and just scratch it on your arm, after a few seconds you get a red flush. Okay? So what's happening there is you're getting a back dumping. So you're getting a normal nociceptive response, but you're also getting a back dumping of the neurons, of the nociceptors, into the tissue. Okay? And that's called neurogenic inflammation. And the cells chucking out things like substance P, CGRP, which are inflammatory mediators. Okay? And it chucks it out into the skin, and it also chucks it out into the dorsal horn. Okay? So you can see that red flush, that red flare reaction we're getting there, again, it's not damaged tissue, it's just you've fired off a nociceptor, and it's now back dumping peptides. And they're basically housed in the vesicles in the peripheral terminals. Okay? So if you were to sort of cut yourself or burn yourself, in fact next time you do accidentally burn yourself, you may get a white sort of bit of scar or a raised bit with a plasma in it, but around that you'll get a red area. And that red flare reaction is this. It's the neurogenic inflammation, and it leads to an area that is slightly bigger, so did it enlarge? You can't see the colours very well, it should be bright, it should be red, but see the dumping neuropeptides? And now that area, you've got an enlarged field, receptive field. Okay, so the initial irritation of the tendon is now caused to an enlarged receptive field that is now hypersensitive. Okay, and that's called peripheral sensitization. Alright, so that area now, around the tendon, it should be red rather than whatever colour that is. It's all gone brown. That area is not damaged tissue at all, it's just an area where these branches of the neurons have dumped out chemicals, but now if you touch that area with a pinprick, you'll get hyperalgesia. Okay, so when we get any sort of strain, we'll get a bigger area around that protected to try and protect. So when you get your burn, you get a nice red flare reaction around it. Okay, it's not damaged, but it's hypersensitive to both heat and mechanical stimulus. Okay, so next time you do burn yourself, get your pinprick out, test it, it should be more painful, but put it near to the flame and it's hot. Okay, and that makes total sense. If you just burn yourself, your body wants to tell you not to go any closer to the flame. And the mechanical sensitivity is so that we don't use our hand as much, we allow it to heal. So it kind of stops us from doing things. So very important, and if you don't have that, you actually don't heal properly. So we need these inflammatory markers to heal. If you look at people like with diabetes who've got reduced sort of number of nociceptors, they don't get a proper inflammatory response. Okay, and it leads to ulceration and gangrene, etc., etc. So we do need this nice neurogenic inflammation to be occurring at sites of tissue damage. Okay, now as this goes on, so if you continue to irritate it, or it's a significant irritation, we lead to central sensitization. So can you see how the dumping of neurotransmitters is there, the continuous dumping, and actually this is where substance P, these peptides are really important, they lead to a far reduced threshold in that second order neuron, okay? At which point now these other neurons, so if we remember that picture I showed you, those little interneurons are now able to set off this. So now you have this much bigger area of allodynia and mechanical hyperalgesia. Okay, so you've burnt yourself, damaged tissue, a bit of a red area where it's hypersensitive to heat and mechanical stimulus, and now an even bigger area which is not red and it's not sensitive to heat, just mechanical stimulus. Okay, and that's to protect the whole hand to stop you using it. So with our sort of tennis elbow, you might get sensitization of the forearm muscles, even the triceps. You can go above and below. If you trace it to the sort of spinal segment, it could be anything that's related to segments above and below that. Okay, so that essential sensitization is really important in all tissue damage and injury. Without it, you don't get this protective sensitivity, and you're more likely to damage it. So it happens within minutes and out to hours of any tissue injury. Okay, very, very important. So it happens with peripheral sensitization, and at the same time, or a little bit more delayed, it's either centrally sensitize the area. Okay, so it's good, it's adaptive, we need it, but what goes wrong is when it stays there. Okay, and this is quite often due to genetic issues. It's just to do with the ability of the brain to stop this happening. You've kind of got, there's a braking mechanism that's constantly preventing this from happening. And when you do studies on rats and stuff, in a normally happy, fun-loving rat, it's very hard to create long-term central sensitization. The acute bit happens quickly because it's necessary, but as soon as the tissue damage goes away, the central sensitization winds down and it all goes back to normal. As soon as they stress them out and take away their mums and do lots of nasty stuff and keep them awake and do flashing lights, they cause the tissue damage, and then straight away they become long-term central sensitization. So this is where the sort of the biopsychosocial stuff comes in. The stress, the excessive awareness of that body area, the fear that it may not get better, that all sort of turns off this natural braking mechanism and means that when you do get an injury, it's more likely then becomes a bit hardwired. Okay, so central sensitization should, I've got my pictures now, but it should start winding down if I remember rightly. So it's now causing that area central sensitization, and as the tissue starts to heal, tendon gets better, less input into the second order neuron, and the central sensitization just winds down and it goes back to normal. Okay? So they're two really important things that I need to sort of get across when we move into headaches. Does that kind of make sense? Yeah? Good. So these descending mechanisms I spoke about can either be one of two ways. It can turn the volume up and it can turn the volume down. So these are signals that are coming from the forebrain and from the hypothalamus and other areas, the amygdala, the limbic system, and that's feeding into the brainstem. So it's not very, my neurological anatomy is not great here, but it's in the brainstem here, and then it goes down into the dorsal horn. So we have descending fibres that synapse on the dorsal horn via areas called the PAG, periaqueductal Bray, the RVM. You heard of these things?
Earlier what Helena was talking about being a headache person, what is that noise? Because it's driving me nuts.
Yeah.
Stopped.
What's that one?
I can't concentrate that.
I think it stopped when it was an order.
It's just a speaker on full. Okay, so we also have these mechanisms coming from the brainstem which are putting a brake on, as I said, but they can actually also turn the volume up. So they can hyperpolarize the dorsal horn and make it more likely to respond to a nociceptive input. Okay, so these are the things, these are our biopsychosocial factors. This is our, as I said, stress, anxiety, depression, but also being overly focused on it, fearful of it. And when we look at headache patients, that in-between period, the interictal period where they don't have a headache, is almost the worst bit for them, because there's that fear looming that's going to happen. Once they get the headache, quite often they say, well, at least I know what to do now, take painkillers, go into a dark room. It's that kind of foreboding, looming threat that's appearing. And that is kind of firing this area off and creating an increased sensitivity. Obviously in the trigeminal system, not in the arm, but we'll move on to that. Okay, so descending facilitation will turn the volume up and make it much more likely when you get an injury for it to become more painful, more sensitive, and also these pathways kind of stay there, they become a bit of a hard wire. They should become learned like memories. Okay? And central sensitization is the same, exactly the same synaptic process as long-term learning. It's how synapses learn to, synapses are fired together, wired together. So if you have a continuous pain for a long period of time, and you haven't got the natural break, it can become an almost permanent synapse. Okay? Again, big issue with migraine, especially when you get chronic migraine sufferers. Okay, so it's descending facilitation. These areas are from mainly the brainstem coming down, and they will, as I said, hyperpolarize the dorsal horn. Okay? At the same time, luckily, we have endogenous analgesia. We have the ability of the brainstem to dampen down nociceptive input. Okay, and now this similar pathways from the forebrain to the limbic system, midbrain down into the dorsal horn. But this will do the opposite. It will reduce the likelihood of a polarization occurring. So you reduce the ability of that nociceptor to actually fire it off. And if you look at stress-induced analgesia, so you're playing football or you're running away from a war zone and you get shot, you don't really feel it, and therefore there's still lots of nociception happening, but your brain doesn't want to know about it at that time. So it blocks the transmission at the spinal cord level. All right? And that's really important for us for a day-to-day basis, but if you think about our patients who maybe don't have this, and actually with chronic migraine, chronic tension type headache, it's a deficiency of this, which is one of the big factors that they get regular continuous pain and the headaches get worse and worse and worse. So they lose the ability to naturally inhibit the synapses. Okay, so that was just basically a bit about central and peripheral sensitization. Okay, so let's take that into the trigeminal system. Trigeminal nociceptive territory is pretty much everything except for the brain matter. Yeah, the dura, the blood vessels, muscles, ligaments, etc. Anything kind of from C1 and above has nociceptive neurons in it. So first order neurons. It will be going to a dorsal horn, but in this case we called it the trigeminal caudal nucleus. So our dura, and these, the V1, V2, 3 that we all learn, the different branches of the trigeminal nerve, I think we're happy with. They're the equivalent of your peripheral nerve. So they're the equivalent of your median nerve, your radial nerve, etc. Okay, so they're your first order neurons, your primary neurons. So if you do have, and go back to what Mark was saying about the secondary headaches, something in the ear, the jaw, the cranium that's pushing on nociceptors will give you a head pain, but that's a nociceptive pain coming from stimulation of these nociceptors in wherever they are. So you've got a space-occupying lesion, it's going to be pushing and stretching mechanoreceptors and they start to fire. So your headache is being caused by something. Yeah, your head pain is an input, being caused by an input somewhere. And if you take it away, hopefully the pain goes away. So you can see dentists, they fix your jaw, or you see an osteopath, they fix your jaw, the pain can go away. Some people have glasses, it takes the strain away from their eye muscles, pain goes away. Okay, so that's all nociceptive pain with maybe some peripheral sensitivity if it's been going on for a long time. And it's involved in the trigeminal system, but more the peripheral nerves and sort of normal pain pathways. Okay, whereas the primary headaches are quite different. Primary headaches, something inherently within the brain stem and the nervous system is causing it. Okay, so the big difference from a neurological point of view between the secondary headaches is that there is something that's irritating nerves, causing a nociceptive pain. Yeah. So if we break down the trigeminal system, and this can get really, really dry, so believe it or not, I'm trying to make it as easy and light-hearted as possible. Here's the trigeminal sensory nucleus, so here's the ganglion, similar to your spinal ganglia, and there's the three branches of the trigeminal nerve. Then this is the trigeminal sensory nucleus. This is equivalent to the dorsal horn of your spinal cord. Only two of these. And then the sort of the caudal nucleus, which actually becomes the dorsal horn of the C-spine. So if you cut it into little bits, there's different shapes of it, but the actual neurons and the pathways are very similar. Okay, and similar mechanisms. So all that synaptic change that you mentioned occurs there as well. So we need to know a little bit about the territory, the fact that you have a similar analogues to the dorsal horn, etc. And then otherwise the pain system is the same. It's a first primary afferent, nociceptive, then it goes into spinal cord. It may be inhibited, it may be turned up depending on the state of the person, what their belief systems are. And then that goes into their sort of complex neuromatrix of pain, of whether or not is it a threat to the system. And when we look at pain, it's very much, is this a threat? Yeah. So if you're running around, you knock yourself, you're quite busy, the next day you've got a big bruise on your leg. Obviously that knock was not relevant, it wasn't a threat to that person. Therefore, you had lots of nociceptions, you bruised yourself, so there must have been tissue damage, but you didn't really notice it, because it was the least important thing that day. Yeah. Whereas if you're a ballerina, you've got a big show on in a week's time, you're running around, you suddenly knock yourself, you may have an excruciating pain in the leg, because for that person at that time, this is a threat, a serious threat to them and as an individual. So this idea of threats is basically how much of a tissue damage there is. And with headache it's different because there isn't tissue damage, is there? They have an injury, they have a headache period, then they don't have one, it comes back again. So the difference there, I guess, is the inflammatory mediators that cause it, but also the fact that it becomes slowly sensory sensitized to the point where normal input may be firing off these mechanisms rather than any particular tissue damage. Okay, so the dermatomes versus the sort of peripheral nerve territories. We've just mentioned the ophthalmic and the maxillary divisions. Yeah. So that's the one on the left. I haven't got a picture of that, I don't think. That would be, well, sorry, it's not coloured in, but you can see the lines. So the top part here, middle 3, that's your peripheral nerve territories. Okay, that's coming from the peripheral nerves. Okay, when we go deeper into the trigeminal nucleus, now we're looking more like the dorsal horn and the dermatomes. So what are the dermatomes of the face? I can't remember what happens when you get slipped cerebellar tonsils. Remember that from undergrad stuff? They slip in and then it causes a curve malformation, but then that leads to kind of block CSF, which pushes on the what's it called? And they come in with the cave and stocking phenomenon. Remember that from neurology. So normally with sort of dermatomal stuff, you might think L5 going to the leg. But if they've got a block in their neck, it starts off as paresthesia and numbness in their neck or their shoulders, or C5, then C4, and it gets worse and worse, C3, C2, then it gets to C0, and then it gets into the trigeminal nucleus, and then it becomes a balaclava type thing, until it goes all the way top. So the dermatomal analogue of our lumbocervical segment would be that coming forward. And with headaches, that's really relevant because it goes the other way down. So the longer you have something, migraines say you're getting tenderness in the scalp. They then may say they start to get tenderness in the back of the head, into the neck, and some of the allodynia scales that we use, and I'll show you one in a bit, it says, do you have sensitivity with necklaces? Do you have sensitivity wearing shirts? Do you have to take your rings off when you have a migraine? And that shows clearly that you're getting this opening up of the sort of trigeminal the nucleus going down into the C0, C1, C5 and down. So mapping out where they get hypersensitivity is a nice way of sort of plotting the transition of how essentially sensitized they're becoming. Okay? So I'll show you one of these allodynia scales, but that's kind of why they say, are you ring sensitive? Do you have to take your necklaces off? Because it's this slowly expanding central sensitization. It's not the same as the Arnold-Chiari one, obviously, but it's a similar sort of central mechanism. There's also lots of convergence on the trigeminal nucleus from the 8th, 9th and 10th cranial nerves. Okay, and again, these are sort of, they're masked, hidden into neurons that just don't do much, but they are there. So in rat studies, they can stimulate the vestibular apparatus via the trigeminal nucleus and vice versa. So the evolutionary reason for this, we're not quite sure, but the anatomical links are there. So a lot of migraines, they get vestibular migraines, they get dizziness, and they think they're having a stroke, or they get tinnitus, etc. So these links to the other sort of cranial nerves are really important, other parts of the brain. And you can see down here, we've got these neurons that are coming out into the blood vessels, and these are sort of nociceptors. I don't know who to share the love with the infrared thing. Yeah, this is that back dumping of chemicals. It can come from these neurons and dump into the blood vessels. So we mentioned they can cause a sort of mild inflammatory response. So they can cause a mild inflammatory response in the blood vessels. So with migraine, you said throbbing, didn't you? So that sort of old theory that it's a vascular issue because it's throbbing. You can see why they came to that. When you bend forward, you get more pain. See, well, that's obviously volumes of blood and stuff going into the head. It's pulsating, so it must be vascular. Now we know that actually the amount of pulsations is not different. The amount of change in intracranial pressure is no different to normal. It changes slightly, but I can deal with that. It's normal. It's not a threat to me. These become so sensitive that they now pick that up as a threat. So the threshold at which they would deem it as damaging or dangerous is going right down. So now the normal pulsation of a vessel is firing off these nociceptors and giving the sensation of a throbbing pain. When you bend forward, that change in pressure in the dura is then setting off and making the brain think that there's potential damage there. So the vascular theory has moved on to this idea of central sensitization within the neurons that are in the dura, within the blood vessels. Does that make sense? Yeah. Okay, I don't know how much you want to know about the mechanism of the pharmacology. Is that something that'd be useful?
Yeah.
So this is just some of the pharmaceutical drugs on offer. But so this idea, if this is a primary neuron and a secondary neuron, but this time this is in the trigeminal system, and this is the blood vessel at the beginning. So we've got first order, second order blood vessel. When these have become irritated and sensitized, and we don't quite know if that's coming because of dumping of debris or whether it's a primary issue with these neurons, but they become sensitive, they start to dump out chemicals into the periphery, the blood vessels, and also into the second order neuron. So this one becomes sensitized, so this could be into the dura or it could be in the blood vessels. It becomes sensitive and you start to get pain and throbbing. So just the normal pressure of the blood vessels is starting to set that off, giving a painful response. So the brain thinks there's damage somewhere, but it's not so much a huge amount of inflammatory chemicals, it's partly that neuron is sensitized, the threshold's gone down. Alright, so you get pain and throbbing, but you don't really get allodynia initially, you don't get that increased sensitivity till later on. And when you give them the triptans, what that does is that sort of blocks the release of these neuropeptides. So the green stuff there, the triptans, they block the endings and you don't get the dumping of these peptides, this substance P, etc. So you hopefully, if you're getting there early, and quite often people talk about a window, they take it super quick enough they can abort their headache. That leads to a complete abolition of pain. So they lose the pain, they lose the throbbing. Okay, but that has to happen quickly. You have to take them quickly before you get essentially sensitized. I'll give you slides at the end, so I'm just saying all the text there. Okay, once it becomes essentially sensitized, so now you can see the second order neuron has become sensitized, and that's because the first one is dumping chemicals into it and it's making the threshold go down and it becomes more sensitive to all stimulus. You still have the pain and throbbing, but then you start to get this allodynia. You start to get this pain from a non-noxious source. So you touch your hair, it's painful, touch your earrings, painful. So you get the allodynia. So that comes on a little bit later. Now, triptans no longer, they can help with the throbbing, but they don't really help with the pain, and they definitely don't help with the allodynia. Okay? Because this second order neuron in the trigeminal nucleus is now sensitized, and it stays there for an undisclosed amount of time. Okay, it's very variable to the person. So, in this case, other drugs are more effective. So actually, COX inhibitors, anti-inflammatories, seem to be quite good for some reason because they affect the synapses of the central nervous system. And then you have those neuromodulators, amitriptyline, gabapentin, which can affect that second order neuron. So in the beginning of a migraine, okay, if you get triptans in quickly, it can abort the headache because it's affecting that first order neuron. If you miss that window, then they need other ones such as strong anti-inflammatories or the amitriptyline, the gabapentin. Although amitriptyline tends to be used as a preventative one to stop that second order neuron going really low. So one of the problems with chronic headaches and chronic anything is that threshold stays permanently low. It doesn't take much to fire things off. So the idea is trying to bolster and increase that threshold so it takes less of an irritation to set it off. Okay, this is the one of the allodynia questionnaires. So you can see from that it has combing your hair, pulling your hair back, which of these are unpleasant or painful, shaving your face, wearing eyeglasses. Can you see, if you think about the topography of that, so C0, C1, going down the neck. So eyeglasses, obviously facial, contact lenses, earrings, we're moving into potentially occipital territories. Then you go down to necklaces, you're looking at C3, going into tight clothes and taking showers, more general. Does it have rings there? No. Okay, I'll put the last background because when it's really bad, it can spread all the way down to that far. You know, you've got an extremely sensitized system. The worse it gets, the more central sensitization is occurring, and the more likely it's going to transform into a continuous headache, continuous daily headache, or transformed migraine. So these sort of things are really useful, whether you use it as this or whether you just ask those questions. So you want to sort of be mapping out over time. So you may be helping them with their acute episodes, but in the longer term picture, is it getting more and more sensitised? Hopefully we're not. There's no studies on this to see whether we help it, but I'd like to think we can. Okay, so is this trigeminal system a threat? I've talked through it, so I'm going to skip that slide. So we've got a primary headache, we've got a secondary headaches, but I'm trying to put this into a more of a global picture of pain. Is it some tissue damage, etc.? So it's a secondary headache. Where's the cause? Is it a primary headache? And then you're looking at what other things are feeding into this. So what sets the trigeminal system off and makes it suddenly go into a headache? And this could be anything that feeds into the system, just dripping away, irritating it. So this is where your upper neck irritation could just be causing the threshold to go down a little bit. It could be a jaw problem, just causing it to go down a bit. It could be an eyesight problem. Yeah, each thing is just going to feed into it, increase the load on the trigeminal nucleus, and make it slightly more sensitive. Then they're quite stressed and anxious. They've had a really bad night's sleep. They're worried about other stuff. All of it feeds in and just reduces the ability to normally inhibit sort of nociception. So that endogenous analgesia talks about, that ability to dampen down inputs, that starts to become eroded, starts to become less efficient. So when we think about primary head pain, obviously red flags, everything's essential. We need to know the demographics, all that sort of stuff, but also in terms of how we manage them, you may want to think about this in terms of what's the sensory input to the trigeminal anyway, so all the bits we learned in our undergrad stuff. What's the dysfunction of the anti-nociceptive system like? I'm sorry, all the terminology is really long and complex. Yeah, how can we work that out? There are ways of testing it. Just generally, how sensitive are they to any sort of pressures? What's their pain threshold seem like? When you're treating them, are they kind of like really jumpy and they seem like they've got low thresholds? But all the sort of social and psychological issues that not issues, but you know, the levels of mood that week, their anxiety, all those things that we look at, the sleep deprivation, that would all feed into it and turn off their ability to dampen down normal input. Okay, heavily deficient in tension type headaches. Loads of studies to show that. Similar in migraine, but less consistently. Okay, and then there's a perception of pain. We call it a facilitated segment, just like we do in the neck or the lumbar spine. But it'd be a facilitated trigeminal system. Okay, and there's this idea that the perceived danger, and that's the sort of prefrontal cortex thing, but this is where getting to know our patients and understanding their life events are really important. And it's sort of clearly documented where people have better patches in their life, they seem to have less headaches. Having the headaches becomes a mission that they're trying to find what's causing it. They maybe find that they think that some food types are causing it, so they're trying to remove them all from the diet, and now they're not socialising anymore, and that can be more impactful than the bit of gluten or the nitrate that may be irritating it, sort of thing. So it's all about that person and their sort of nervous system and how much it perceives it as a threat. Okay, you may also get, I don't know if I've got one picture shows this, but I don't want to go into cluster headaches and stuff, but the idea that you get the parasympathetic side of it, you get sort of increased mucosal sort of fluids, and you get changes in the eye, etc. That's very much down to the trigeminal system feeding into the parasympathetic system, having neurons attached to it. So, again, that sort of headache is very different, but the symptomatology is all based around the trigeminal system. So headaches, the different types of headache, it's why is it causing a left-sided one that's throbbing versus why is it causing a really intense cluster headache with the parasympathetics. So we bracket it into these different types, but underlying it, it's probably more like to be a neural mechanism that's different for each one. Or it's a bit like lower back pain with sciatica, or lower back pain without sciatica. Okay, so there's probably these models will change in the next few years. Okay. Just to be aware that the temporal pattern, the chronology of headaches is really important, because people may have a migraine as a kid, it goes away again. They then maybe get face pain Okay, it's dealt with hopefully well, but sometimes these things persist, it's almost gone, and they get jaw pain. Okay, then they start to get tension type headache as they're older, then their migraine comes back. And you should be plotting this course, because the more frequently these are occurring, even if they are different, any trigeminal input, probably, and I say probably because we don't know this for sure, but we'll be tapping into the ability for the nervous system to become sensitized. And then that can lead to this idea of a transformed headache, so a chronic daily headache. Okay, got a lot to cover. The trigeminal nucleus, trigeminal cervical nucleus, I've already sort of touched on that. That is basically where the cervical, dorsal horn and the trigeminal bit meet. So there's no magic to it, it's just the area from C3210 trigeminal. Okay, they call it the trigeminal cervical nucleus, and it is just the dorsal horn analogue in the brain. Okay, but it's very relevant to us, obviously, because people with headaches come in with neck pain, people with neck pain get headaches, and there's obviously a big crossover and referral from that. So this is from a paper, I think, by Bogduk, and it's looking at facet referral patterns. So you can see the darker black bits, that's where the majority of people get pain. And if they stimulate C12, 95 to 100% of people feel it at the back of the head there. About 7% will feel it on the top of the head. If they stimulate C23, here, a large proportion will feel it in the front of the head. So we see as we go, weirdly enough, as you go down slightly, it actually goes more forward. And that's just because of the growth of the embryo and where it's taken neurons. Okay, but we know that the upper cervical complex, the C1, 2, 3, will all refer pain into the head. And I think we all know that as practitioners, and sometimes if it's really sensitive, you can get right in there on the suboccipital muscle and recreate their headache. Okay, same sort of thing here. So this dark area here, 90% of people with C23 problems were getting pain on the side of the head. And this one here, 80% of people with C23 were getting pain here, 90% here. So we know that these areas refer pain to the head. So this cervicogenic headache could be from a cause. Cervicogenic is a secondary headache because the idea is if you get rid of the problem in the neck, you get rid of the headache. And the diagnostic category for cervicogenic is partly retrospective. Does it go away by treating the neck? Which is a bit hard to diagnose in the first session. This is from Bogduk, just showing you pictures here. So again, cervicogenic headache from C0, C1. A lot of people get their temporal pain here, frontal pain. Yeah? So I think we're all happy with cervicogenic headache. I assume we all sort of treat it in clinic. But what are the links between migraine and headaches? That's a sort of upward, bottom up kind of picture, isn't it? It's the neck feeding into the headache. So here on the right, you can see C3 spinal nerve 2, 1, all feeding into the dorsal horns there. And then the second order neurons have lots of interneurons, which connect different segments. So just like you've got a C5 irritation, the longer it's there for, it starts to unmask interneurons above and below that. So now you get a bit of C3 and a bit of C6, maybe. It starts to spread, maybe it goes down to C7. So now they're getting that somatic referred pain down their arm. And that's the spinal cord sort of opening up a little bit as these interneurons become active. So it's the same principle here, really. You get the areas of the neck, you may get nociceptive irritation from the ligaments, the muscles, overfiring of the muscles, anything that could be causing a stimulation of the nociceptors here can feed in and either cause a complete referred phenomena or start to open up the interneurons and cause a spreading sensitivity. And here you can see the spikel inputs coming in here, the trigeminal inputs here, and it all mixes in the trigeminal nucleus caudalis. And there's links with the sort of salivatory nuclei and the sphenopalatine ganglia, which link in with the eye. So that's your sort of parasympathetic cluster headache type link, trigeminal link, and they all have links to the vasculature and inside the whole head. Yeah. So you can kind of see how irritation in the C1, C3 segment can start to irritate and cause either acute sort of peripheral sensitization that can open these up, or more prolonged central sensitization, and then can link in via the trigeminal, causing either referred pain. If it's referred pain, it's literally the brain is misinterpreting it. It thinks it's coming from the forehead, but it's coming from here. Okay, so it's not actually necessarily a neurological synaptic thing, it's more the brain misunderstanding that there's two potential sites of interaction. One's from the neck, the neurons also feed into the sort of forehead via several interneurons, so it misrepresents it. The other thing would be the spreading irritation and sensitization. So someone who's got chronic neck pain can start to spread up and theoretically start to causes the trigeminal nucleus to become more sensitive. So if you have someone with headaches and then they get a neck problem, it's going to fire their headaches off. So this is a kind of what we say a bottom-up effect. So neck problems feeding into the headaches. But we also get purely headaches that can then cause primary headache, which can cause neck symptoms. So similar pathway, something kicking off the trigeminal nucleus will then start to sort of open up these interneurons going down into the C1, C2, and just like the facilitated segment we learned, it sort of increases the activity in the neuron pool, and it can increase the motor response for those segments. So now you start to get C1, C2, C3 muscles, so the upper neck, splenius, the splenia, longus colli, etc., can all start to become a little bit hypertonic, a little bit increased in their activity in an attempt to guard what the nervous system thinks is a threat. It thinks something's damaged in the neck, therefore tighten up, protect. It's a sort of all or nothing response we have to pain, really. Okay, so leading into the very last bit of that. So basically you can see how it becomes sensitized, how it can spread up and down, and then because of obviously the motor pathways to the muscles from these areas, we get quite very relevant to us, but changes in the motor system. So when we talk about deep cervical flexors, we've got longus colli, longus capitis here, so that's on the anterior neck. You've got the anterior scalenes and the SCM. So longus capitis, longus colli. So the deep ones are the longi, and the superficial are the SCM and the scalenes. I'm going to jump back to this actually. This is obviously a sort of a knee joint or any joint you want, but the idea being that if you irritate a mechanoreceptor or you've got some inflammatory chemical, anything that could be firing off nociceptors, you get obviously a sort of nociceptive message that then causes a response that may be tightening of the muscles. You also get a bit of backdumping of neuropeptides, but the resulting effect for the muscles will be either increase the tone to protect and guard, or decrease it to take the strain away from it. With the lumbar spine, and when you have low back pain, you get a reduction in activity of your deeper ones, so your transverse abdominis switches off, and you get an increase of these sort of obliques and the larger muscles, the glutes, etc., because they're going to try and stabilise and protect while turning off the deeper ones that could put localised pressure on it. So you start to get wasting of your deeper ones. With the neck, it's very similar. You start to get wasting and fattiness in your longus colli and capitis, okay, and you'll start to get an increased tone in scalenes and SCM. So the bigger ones are trying to stabilise, as well as when we move, you're getting a bit of much more guarded movement. And when you see scans, jump to this one. Here, SCM, this is a ultrasound scan of the neck, so surface going deeper, vertebral body. So VB is vertebral body, SCM, and this is the longus colli. Yeah, you can't see too well here, but you can see the mark, can you, the size of it, quite a high depth. Here, you've got a much more shrunken one. So on average, you get a fairly significant reduction in size of your deep neck flexors. So that's your longus colli here, vertebral body, and here, much more smaller. And quite often it's fattier, it's sort of fatty tip infiltrate into it, it's not as structurally stable as you'd like it to be, or structurally sound. So over time, with headaches, it's the same sort of thing. You start to get a switching off of those muscles in an attempt to protect the neck. And obviously it's the headache, the primary headache that's causing this, but due to the misrepresentation, the brain thinks it's the neck, starts to shut off supply to that area. And to protect it, so otherwise your head would just flop around, it has to tighten up the outer one. So you do get an increased tone on the scalenes and the SCM. And I think we see that in our treatments when examining the neck, we see that. But you also get altered proprioception, so the ability to position the head properly can change slightly. This is not 100% definite because some studies show that it's not the case, but a lot of studies do show that there's a loss. So, for example, if you get them to close their eyes, move their head, and then open their eyes again, they may overshoot. So you can kind of test the proprioceptive ability just by asking them to point forward. And in the research clinic, they do it with lasers on the head and they have to point properly. And the other thing is to do a figure of 8, and you need a laser for this, but if you have a laser pointer on their head, they do that, and then they try and position it again, and it offsets, and they can't do that, or they look at the shape of it, and it's much more erratic. So you lose not just control, but stability and movement. So lots of changes to the muscles occur. We get increase neck pain and disability increases migraine. Chronic migraine more than tension type headache. So increased EMG activity of the neck muscles during exercise. So when they try and do stuff, they're going to be firing more than they should do. So there's a stability issue, there's an over guarding. But also mental tasks. And I found this really interesting. So even when they're doing mental arithmetic tests and stuff, they will get increased activity in the neck muscles. So somehow they've lost that ability to just keep it nice and loose and floppy. I think for treatment, that's one of the things we're trying to do a lot. And migraineurs exhibit altered motor control. As I mentioned, the greater co-activations. They try and fire one muscle, they fire the other ones. Try and fire that side, they fire these ones. So they're now unable to do small, discrete, isolated movements, which then leads to more potential strain on ligaments, etc., which leads to more potential nociceptive input, which then feeds into the headache. So it's a bit of a whiz through that, but in terms of like treatments, I know a lot of migraine specialists say that there's no link between the neck and migraine. I've heard a top doctor say that. But he injects the main ring of muscles for migraines. He injects the frontal muscles and the capitis muscles. But we know for a fact that C23 goes into it. I don't know how they can say that because the neuroanatomy is well known. So one way we can check this in clinic, okay, is the cranial cervical flexion test. And I'm just going to mention it, and then I think after Liz's talk, we'll maybe practice it as well. So this is a test to see if the cervical flexors are dysfunctional. And we're looking for weakness, but fatigability as well. Okay, so what you do is you lie your patient on their back. You need to get your forehead, or their forehead, and chin level. Okay, so you may need to prop their back of the head up with a pillow. Okay, so they've got a large kyphosis, so you have to put quite a lot to make sure their head and chin are on the horizon, or on the horizontal. Okay, then you're supposed to do it with the cuff. I actually cheat sometimes, we'll do that later. But you get an uninflated pressure cuff, so you get your spig, and you put it under their neck towards the occipital end, and you just gently pump it up to about 20 millimeters of mercury. So you're just inflating it a little bit with a bit of pressure, so it's just sort of touching the back of their head, but not lifting their neck up. Okay, that shouldn't be enough pressure to actually inflate their head off the pillow. Okay, then what the patient does is they try and nod. Okay, and nodding is very much the rectus capitis and the longus muscles. So doing a gentle nod, they shouldn't be using their cervical superficial flexors, their SCM, their platysma, etc. It should just be deep cervical flexors allowing that nodding motion. So you get them to nod, and hopefully they can, if they haven't got any problem, they should be able to do it without massively changing the pressure in the cuff. Okay. Then you get them to look at it, and they try and increase it by 2 millimeters of mercury for 5 and hold it for 5 seconds. So you're doing a little gentle nod, and then 5 seconds and you relax. Then they try and do it to 24, 5 seconds and they relax. Then they try and get it to 26. Each time they're just doing a bit more nodding, a bit more pressure. So there is some vertical force there. 26 millimeters, 28 up to 30. So they do it from 20 to 30. So 5 rounds. And what you're looking for is how much these stick out. Okay? The platysma, the SCM, the scalenes, they shouldn't be active. So when I said I cheat, why often I just palpate their neck? So I get them to do biofeedback and actually palpate themselves. So can they nod, lie on their back, without firing these? Yeah, a lot of people with headaches or chronic neck pain, they just do that, or they just try and come off the couch. So just get them to palpate these muscles and see if they can do it without isolating it. And if they can't do it, it's kind of good because it means there's something a trick they can take home, and they can do that biofeedback. Palpate their neck and see if they can nod without firing. So we'll have a little play of that later. If it is deficient, then in the physio world they talk about retraining it by supporting the neck in a bit of flexion until they can do the test properly. Okay, because it's just easier when you're lifting the neck up slightly. You're taking off these superficial muscles. Then they learn to retrain it, and then you can slowly get them back to the flat. So to do it properly takes a bit of time. It's a proper exercise treatment. I don't tend to do that personally. I do, as I said, without the cuff. I just examine it just to show people that they're not doing it, and then give that as homework. But ideally, you want to increase make it less fatigable and increase the endurance of the muscles by using that cuff. Okay, so we'll have a little practice of that later, I think, and then that's it. So there's a lot to get across. I'm sorry that it's just like pretty heavy. But,